There we go. Welcome to our afternoon session on palliative care, what every rural nurse should know, presented by Dr. Audrey Snyder. We are very grateful, as always, that you make the time in your schedule to join us for these informative and interesting webinars. I know everyone is incredibly busy, so having you here with us, we are always appreciative of that. Before we get started, I just want to do a quick housekeeping. We do have plenty of time at the end of our webinar today for questions and answers. You are welcome at any time to use either the chat or the Q&A feature to record your questions so that you don't forget it along the way. Just please know that we will be holding that until the end of the webinar. At the end of the webinar, if you would prefer, we can also unmute your mic so that way you can share your question with the group. I would love to introduce you to Dr. Audrey Snyder. I am quite confident that most of you on the call have already been introduced to her either with previous webinars or through your practices. Dr. Snyder is a professor and dean for community engagement and academic partnership in the School of Nursing at the University of North Carolina, Greensboro. She is also a nurse practitioner with Cone Health Palliative Medicine Program and is certified as an acute care and family nurse practitioner. Audrey is a founding member of the Global Rural Nursing Exchange Network and has been honored as a fellow in the Academy of Nurse Practitioners, the Academy of Emergency Nurses, and the Academy of Nursing. Her significant contributions have focused on promoting access to care for rural and under-resourced populations and decreasing barriers to access advanced education for rural nurses. And with that, I would love to turn this over to Audrey so she can start your presentation today. Thank you for being here.
Thank you, Stacy, for that wonderful introduction. Welcome, everyone. I see we have about 16 participants. Could you type into the chat box where you're from? I'm just curious, who's joining us today? While you're doing your messages in the chat, I am going to share screen. Trish is on from Reidsville. Now that I started sharing, I can't see where everyone is from. Stacy, do you mind reading out? Who are all our guests today?
I would be happy to. We have people joining us from Reidsville, North Carolina, quite a few people from South Dakota in both Vermillion and the University of South Dakota. I'm not sure if that's the same campus. Let's see. Charlotte, North Carolina. More from Vermillion. So it looks like we have a lot of our colleagues from USD joining us today. So that's wonderful. Thank you.
Great. Thanks for sharing. So I was asked if I would talk about this topic. I have worked in palliative care, both in the rural and the urban environment. I've worked in palliative care from the perspective of being in a hospital and providing palliative care to the rural area around me. I've also worked in hospice in the same way. And so there's been inpatient hospice, outpatient hospice, palliative care, outpatient, and palliative care inpatient. And currently I'm in a role in inpatient, but we do a lot of referrals to outpatient palliative care. So I encourage you to write down your questions because it's a lot of material. I want to try and make sure I get through it. I'm happy to share my slides with you, so don't worry about trying to write down everything. And I know that it is being recorded and that will be available on our webpage. So the objectives for today's presentation are to just do an overview about principles of palliative care, to talk about the role rural providers have in discussing and managing advanced and chronic illness, talk about advanced care planning processes, and describe the management of some commonly occurring symptoms that we see in palliative medicine. So to start with, I'm just going to try and work on those definitions of hospice versus palliative care. Because with hospice, we really are focused on end-of-life care. In order for any patient to be covered by their insurance for hospice care, someone, a physician, a nurse practitioner, a PA, has to sign a paper in the United States that says this person is expected, this person's life expectancy is less than 6 months. Palliative care, on the other hand, can be even for a child, can be for someone who has a chronic disease diagnosis that could potentially be life-limiting, and they can receive treatment, even aggressively, the whole time that palliative care is following and focusing on symptom management and comfort for the patient and the family. So lots of times in the acute care environment, we're looking at what is aggressive curative care versus what is palliative care. And aggressive or curative care, we know that we're making quick decisions in the hospital as providers. It's a pretty intense, it's pretty assertive, and the goal is treatment and hopefully improvement or cure. Whereas with palliative, what we're focusing on is really those symptoms. We're focusing on preventing additional discomfort. We're trying to relieve suffering. And we're, again, working with people who have life-threatening diseases, but patients can still receive all of the intensive care therapy that they are choosing to receive, you may say. So if they have a cancer, they can still get chemo and radiation. Really, it's just about how do we improve their quality of life? How do we ensure that their wishes are made known to the healthcare team and honor those wishes with the work that we do with them? So the World Health Organization definition of palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illness. It relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether it's physical, psychosocial, or spiritual. And we know that all of these can be a challenge. And this is one of the reasons why many palliative care programs have a chaplain or spiritual support person as a part of their team. They may have a case manager and definitely a social worker to address social concerns. You know, in general, when we think about, what happens to patients, what are the trajectories of death? For those who work in an acute care environment, especially my experience of working in the ED, someone may come in dead on arrival. EMS has attempted to resuscitate them, or maybe they come in their family's car in the back seat. There may be resuscitation in the field or resuscitation in the hospital that follows, and they may die in the hospital. We have patients who are known to be terminally ill. Maybe they have a stage 4 cancer. Sometimes we have people who are very frail, and maybe they've been in and out of the hospital multiple times in the last 6 months to a year, and they may be hovering near death. For others, we see a slow decline. They go from being able to drive themselves and go places to not being able to drive and being homebound, then maybe to being homebound in a bed or in a wheelchair as opposed to getting up and moving around their house. We have people who arrive alive to the hospital and then suddenly may have a cardiac arrest or a sudden death. And then there's also potentially preventable deaths that are from acts of commission or omission that can occur, and those we hope to not have happen. So with palliative care, it doesn't matter where the person is in their disease trajectory. They can be referred at any time. So the goal would be for them to be referred at first diagnosis so that the team can support them and provide that spiritual and emotional support along with addressing their medical concerns. As I said, they can continue to receive all of the aggressive treatments at the same time. And we realize that globally, the healthcare system in the United States is very fragmented and disorganized. And there's a lot of incentives to maximize utilization of services. But that has a lot of implications. And so we need to think about, what is the best way to manage symptoms, provide education to the patient and their family, and help them to develop goals of care. And oftentimes when I receive a consult, when I'm working inpatient, the consult just says goals of care, because people who are working inpatient and acute care don't have a lot of time to just sit down and address someone's wishes with them. Insurance will cover palliative care to do a 70-minute consult. So I could have 70 minutes to read their records, talk with them, talk to their family, fill out paperwork if they do decide to do advanced directive paperwork. So it does give us a little bit more time. With hospice being comfort focused, no life prolonging measures are going to happen. And usually this means no further hospitalizations. The person would be kept at home or in the environment they're in. No aggressive treatment, no curative treatments. And we're just going to focus on comfort care. For hospice care, most insurance plans cover 100%. There may be some limits on inpatient days. And if a person is a veteran and they have VA benefits, those VA benefits actually can give them additional services. The challenge is people need to sign up for those benefits while they're still active duty. Realize that when someone goes on hospice care, it's not permanent. So someone could go on hospice care, get some results suddenly of some testing that had been previously done, and say, I really don't want to be on hospice care anymore. I want to try and see if we can treat this. So they can revoke hospice. That's the terminology that's used, is revoking hospice. With palliative care, this is covered under Medicare Part B and is considered a specialty service for insurance plans. So sometimes there are copays that are associated with palliative care services, depending upon the insurance company. So let's talk about a couple of scenarios that could happen. We've got this patient who's a 58-year-old who has a history of 100 years of smoking. He has chronic obstructive pulmonary disease. He presents with difficulty swallowing and chewing, weight loss, inability to talk, and numbing of his tongue. So on exam, he has the appearance of oral cancer. He's admitted for hydration and evaluation. And biopsy and scans are done, and he is diagnosed with oral squamous cell carcinoma with metastasis to his cervical lymph nodes. He agrees to have surgery, and that's treated. But despite the surgery, the malignancy grew with worsening symptoms. And initially, they could be managed. He had pain medications. The disease progressed, his pain worsened, and there really weren't good, effective treatment options. So in talking with him, he actually refused to have any additional surgery, any chemo or radiation, but really just wanted to be supported by his family. So any options that would prolong his life would include mechanical ventilation, an endotracheal tube, and a feeding tube. And when this was discussed with him, he chose to not go that route. He chose to have comfort care instead. Let's talk about another scenario. We've got Mr. Pickett. And I share this because this happens in real life often. He's on hospice for metastatic lung cancer. He lives with his daughter, Joan. She's his healthcare medical power of attorney, but his second daughter, Jennifer, comes for a visit because Joan needs a vacation. He falls, she picks up the phone, calls 911, and he's taken to the emergency room. And it's not until he's in the emergency room that there's a discussion about him being on hospice. So hospice instructs all patients and their family to call hospice before transport to the emergency room, because for some things they will transport them and then hospice takes care of the bill. And otherwise, if a patient is wanting aggressive reassessment treatment, then they may need to revoke hospice to have that done. In this situation, the patient had scans. He didn't have a broken hip, didn't have a bleed in his head or any of those things. And he was able to be sent back home on hospice. But it gets a little tricky on who's going to pay the bill when hospice is not called first. So for those of you who work in a rural environment and are educating patients and their family, remember to tell them to call hospice first if they feel like that they're needing emergency care for something. So let's talk about predictable situations. There are many times when patients come in, whether it's to a clinic they're coming into a specialty clinic, or they come into the hospital. And for all of us nurses, we need to be ready to have these conversations, which means engage with the patient to understand what means the most to them. What are their wishes for end-of-life care? And then steward that information. If there's an electronic health record, ensuring that their advance directives are copied and are in that record and accessible to anyone. Respecting their individual wishes to have a patient-centered care plan. Also, we need to exemplify the use of advance directives in our own lives. So if a patient says, well, do you have one? We need to be able to say, yes, our wishes are known, they're written down. And then connecting the patient respectfully, thinking about their cultural and individual preferences. I do know that in some cultures, that telling someone that they are dying is not an acceptable thing to do. So the work that we do, we want to ensure that we know what their cultural perspectives are and what their wishes are. You have to ask yourself, as you're working with someone maybe who's been in and out of the hospital multiple times over the last 6 months, would I be surprised if my patient died in the next year? And if that's the case, this is a great patient to refer for palliative care. So the goals of care really from a practitioner perspective is to relieve that suffering for the patient and for the family, and to treat not only physical, but psychosocial and spiritual symptoms experienced by the patient. We want to be able to anticipate, prevent, diagnose, and treat symptoms, and really help that patient and their family understand the nature of illness, and determine what's the appropriate medical care that aligns with their goals and those of the healthcare team. So we do need to think about the language that we use. You know, patients may go from inpatient back to home versus they might die in an inpatient setting or die in a hospice home. And we have to think about, what does it mean at end of life? And many times patients may not really realize that's where they're at, that they are coming close to dying. So we have to think about, would they want to hospice care and be kept out of the hospital, or would they want to be re-hospitalized for a medical concern? We want to talk about not just pain, but other symptoms that they may have and how it needs to be managed. And as opposed to talking to patients about do not resuscitate, I talk to patients about allow natural death. And in Europe, this is much more common language than it is here in the US. But if something happened where their heart stopped, they stopped breathing, would they want to be allowed to die naturally, or would they want interventions to be done? And then just the concept of healthy dying, because that's an opportunity for individuals and family members to really reflect on their life experiences. What have their contributions been in their life? Do they have any regrets? What's the meaning of their existence? And value the relationships that they have and what they mean. Many times in hospice care, patients develop very reflective practices. And I've been privileged to be present for a lot of golden moments where families are able to reconcile differences, where people are allowed to really verbalize something that's very important for them. And we have to be empathetic. And a part of that being empathetic as a provider is to be vulnerable, but to also be courageous and to have these difficult and serious conversations with the patient and with their family. So as I mentioned, that conversation ready, engage with them so that you know what matters most to them, steward that information so that there's an advance directive or a post form that's documented and in their record. We actually have days where that we'll have, tables set up and notaries so they can notarize things for people, and have people on hand to talk with people about advance directives in our lobby or the cafeteria, finding a way to try and get that information to patients' medical records. Respect, finding a private and quiet place to talk, and exemplifying the use of advance directives as we talked about in our own lives, and then connecting patients respectfully, considering all their cultural and individual preferences, Try to correct inaccuracies or misconceptions. Try not to use jargon or slang like, do they want us to, quote, do everything, end quote. Lots of times I talk with patients and fortunately, it's usually not a one-time conversation. We have a conversation and we have another conversation tomorrow and another conversation the next day when they're inpatient. I understand this is a very difficult time and I'm providing you with a lot of choices. Talking with them about, well, if they do have a cardiac arrest and interventions are done, how probable is the success of those interventions for them, to really try and understand better what their wishes are related to their care. One of the tools that's really helpful lots of times as a nurse to look at is to do the palliative performance scale. With this scale, it's from 100% down to 0, which 0 is death. But usually at the time, well, I'll say, first of all, for palliative care, a patient can be at any of these percentages and be cared for in palliative care because maybe they just got diagnosed and they're still feeling really good and they're able to work and drive and eat. But when patients get down to 70% of effort, this is a point where it is really important for us to have conversations with them about what their wishes are because of this trajectory of having decreased ability to do the things that they love to do and want to do. When we get down to 30% on this scale, this is usually an indication that we should have those conversations about hospice and work with them on that transition from palliative over to hospice care. We have been working really hard to increase access to palliative medicine in the emergency department. And a lot of academic programs now require the emergency medicine residents to do a palliative care rotation. Also, hospitals are being really innovative on how they facilitate the demand for palliative care practitioners. They, increase, maybe there's a palliative care fellowship. We have social workers that are specialists that's just in palliative care, but to really look at how we can do this. And there are some days when, I walk in and in one day we've got a request for 15 referrals and consults so that we need to do. But what I have found is that the more that I model those conversations, even in the ICU with the physicians present, the more that likely they are to have some of the early conversations still put in the consult, tell you what they've done or how far they've gotten, and ask you to continue to look at goals of care with them. When we have geriatric patients, we really need to think about the complexity of their care because having chronic illnesses and transitioning between maybe home and the hospital and then to rehab or to long-term care, and what does that look like? Managing multiple illnesses, just helping them navigate the complex healthcare system that we have today can be very challenging. And for many of them, they want to maintain their functional independence and trying to help them be able to do that as long as possible. But working with them on their decision-making about care and treatment so that they are well informed to make an informed decision. Ensuring that pain and other symptoms are under control and determining the risk versus the benefits of treatment for this person. Home support for the family caregivers. Caregivers really burn out quickly. And if someone has been in care at home for a longer period of time, then they may need some respite care. We also need to think about what community resources are available for them and help them access that assistance as well. This advanced care planning is really a process. Like we might spark the thinking and the conversation, but many times when patients are acutely ill with a chronic illness, they're not ready to have those conversations. And so it's important that we really read the patient well, but we also want them to be able to think through what are their values, what do they prefer, and to talk about it, and for us to be able to document that while they actually have decisional capacity so that later, when they don't, that someone would be able to make those decisions with them. And we use the guiding principles that all patients have the right, or all persons have the right to decide what will be done with their bodies and that individuals have that ability to make decisions unless it's deemed otherwise. And all patients can participate in a conversation, should be able to. And for sometimes, even if a patient's intubated and on a ventilator, it may be that we've got a pointing board or an alphabet board, or that we have the ability for them to write on a piece of paper and communicate with us. If someone is using sign language, then we should ensure that we have these conversations using an interpreter. And all healthcare professionals can improve end-of-life care by encouraging patients to have that advance directives. So it doesn't matter where you engage with that person at, is trying to encourage them to fill out the paperwork, to have some type of advance directive that is copied and is in their chart and is at home for others to know. Now, this will vary by state, but this is pretty common. So in North Carolina, the order of surrogacy is when a patient cannot make decisions for themselves, their healthcare power of attorney, then a court-appointed guardian, then their spouse, then the majority of their parents or adult children, then comes the adult siblings, and then could be any individual who has established a relationship acting on good faith and can convey the patient's wishes. So if nothing is in writing, this is what we have to go by. Guardian, spouse, then parents and adults and children going forward. The challenge I have sometimes is that patients are awake and they're able to make their own decisions, but they have a healthcare power of attorney and the person named in it thinks they get to make the decisions. And so lots of times we have to remind them that they don't get to make the decisions while the person has decision-making capacity. Some of the advance directives, and it varies by state as to what's accepted, but a living will that states while someone is alive what their wishes are. A living will usually gives very specific information about what kinds of treatment they would want or would not want, or when they would want treatment withheld. It's extremely useful in determining their wishes if they don't have a designated healthcare agent. It is legally binding in our state and usually addresses also things like pain medication, antibiotics, food and water at the end of life stages. With a medical power of attorney, when the patient can't make their own decisions, that person is to communicate those to everyone else. There is the 5 wishes, which 42 states in the US accept as an advance directive. And if nothing else, it's a great tool for end-of-life discussions. Who can make healthcare decisions for them when they can't? What kind of medical treatment would they want to have done? How comfortable do they want to be? How do they want people to treat them? And what do they want their loved ones to know? Sorry, just lost my spot on my notes. Also, with a post form, and you can look this up, it's physician's orders for life-sustaining treatment, do not resuscitate or allow natural death or shared decision-making tool. Some states also accept this as well. And you can look at polst.org to get more information about that. I want to mention this because many of us live in areas where that we have a large minority population. In our area, we do. And what I found in looking at the research is that white patients are more likely to have an advance directive than non-white patients. More than, it's like 50% less if someone is a person of color. But if we do a palliative care consultation, we can actually increase that percentage up to about 40%. African Americans differ from whites in the likelihood to execute an advance directives. And sometimes I think this is historical mistrust that could be a factor, but 11% before they had a palliative care conversation and 28% afterwards. So try to ensure that every patient is receiving information and asked about their wishes and about their advance directives. So some strategies for access: the Joint Commission that certifies our hospitals recommend that we frame the conversation and that a document should be available with every patient's medical records. And then everyone who cares for that patient should know it exists and that a copy should be readily accessible. And then if someone is a designated healthcare power of attorney or healthcare agent, they should have a copy of the document as well. And so we want to look at those documents and see if it reflects the patient's current wishes and preferences each time that they enter our care. And if the wishes are clear, it's a lot easier for their power of attorney to translate that to the healthcare providers working with them. You know, advanced care planning is dependent upon a lot of things, and it is not a one-time event. There are times when I've had conversation for 6 days before we actually get to what they really wish for and what they really want. But communication, differences in values could be a factor, cultural issues could be a factor, their ethnicity and their mental capacity. And I just want to say that allowing patients to tell their story of their life and their illness actually helps them organize the chaos of their lives and to many times then accept what is happening with them. And I would just say working as a palliative care and hospice NP, that's been a big joy for me. The biggest reason I got into kind of this area is because my father did not have a good death and my mother did not have a good witnessing of his death process because he was in a rural community hospital. They did not have hospice services in the hospital or the community at that time. And palliative care, they did not know what it meant when I asked all the questions. So just realize that many times as a nurse, you're going to hear a lot of really great stories with your patients, and that helps them to be able to accept what's going on with them and put their life in perspective. There are some challenges that can happen with advanced directives because maybe they don't understand their treatment options or recognize the outcome of their choices. That's why readdressing them with each time we interact with them is helpful. The patient could also change their mind after having an advanced directive and forget to inform their family. It also could be that it's ambiguous to decide clinical options during end-of-life situations. It might just be too much stress for the patient and for the family. And then there's also some specific directives that might not be useful, like if a new treatment option was available since they wrote their directive. So knowing how long ago they wrote it, what may have happened in the meantime. And I'll give you an example. I had a patient who had squamous cell carcinoma of the neck. They refused a gastric tube, but they failed a swallow test. They failed a barium swallow, but they still wanted to be treated. And, you know, treatment was surgery and then radiation and chemotherapy. And when it came to doing chemotherapy, they were just too malnourished. And so when they said, we're not going to be able to give you chemo, then this patient accepted a gastric tube. They weren't ready to give up yet. And so we had to change their written advanced directives to reflect that. Just think about what resources are available to you as well, because working with persons, you know, at end of life can be very challenging. So do you have the ability of an ethics consult? In our community, it's a lot harder than if a person is inpatient. Inpatient, we can request an ethics consult. Other members of the palliative care team, and if you're outpatient, sometimes the inpatient people can be support and vice versa. Chaplain services, each other, and then, you know, the palliative care team, like I said, you know, vice versa, the team that's on the outside in the community. When we talk about comfort care, what does that mean? So comfort care would be when we have a patient who comes into the hospital and they really don't want more aggressive treatment done. They want us to just focus on palliation of their symptoms, giving them psychosocial and spiritual support, both to the patient and the family. And when that happens, we review the plan of care and decide what's unnecessary. So the goal is to minimize medications, minimize tubing, IVs, minimize blood draws, minimize noise. So maybe moving their room to not right at the nurse's station, but to the end of the hall, creating a quiet environment. And sometimes that may be that it's, having quiet music played in their room, or the station that has beautiful scenery and music on it on the TV. Having the right environment for them to be in as well. We're going to focus on symptoms, and on your screen, you have a long list of symptoms that are commonly associated with patients in palliative care or at end of life in hospice. So we've talked about pain, but breathlessness is a big challenge. Depression and anxiety, delirium, emotional and spiritual distress, nausea and vomiting, terminal agitation, terminal secretions, which was a challenge for my mother to witness, and sedation for refractory suffering. So with pain management, and this has been really challenging for me to try and educate some of the nurses that work within our healthcare facilities, and so I will write, don't take vital signs unless family asks, because we don't want to take vital signs between medications, or maybe we say take vitals once a day. Because if someone is at the end of life and they're in discomfort, are we going to withhold their medication because their blood pressure is a little low? No, we're going to continue to treat them, even if the side effect of the medication could be an even lower blood pressure. Acetaminophen, anti-inflammatories, your common narcotics of morphine, hydromorphone, oxycodone extended release. Dexamethasone works really great for bone pain. These medications could be put on a pump. We have to be really careful. I had a patient who was inpatient but transitioning to go home with hospice, and I was transitioning all their orders to oral medications, and the nurse refused to give sublingual morphine, and it was an LPN who was working. And she's like, well, it's a CC and they're NPO and I can't give it to them. And so I had to do a whole just-in-time little in-service about squirting just a quarter of a CC into the patient's mouth and their buccal mucosa or under their tongue, and allowing that patient to absorb it before giving them the next little squirt. With morphine, we have to watch kidney function. With hydromorphone, if they have liver disease, that's not the best med to give. We can do fentanyl drips if they're inpatient, or any of these medications, as far as morphine, hydromorphone, fentanyl, by a patient-controlled analgesia. And many outpatient palliative care programs and hospice programs have the ability to do PCAs at home. Don't forget about your non-pharmacologic pain management. So would ice packs help, or warm packs, or could we try distraction or music or massage, or just their positioning? Or is this a patient where that palliative radiation might be an option for them for pain relief? We see that a lot with bone pain. Symptom management, that end of life death rattle is what gets many people. You can put a fan in the room. Sometimes that helps with the breathlessness. Thoracentesis or paracentesis might need to be done, because if they've got fluid that's compressing on their lung, sometimes we put in pigtails to be able to drain fluid for the patient to try and keep them comfortable as long as possible. With anxiety and depression, there are lots of meds that may work. And my history experience is that many times one medication will work for one patient and a different medication will work for a different one. So we just have to figure out what's the best for them. Delirium is another challenge, and terminal delirium is something that is frequently seen at the very end of life. And, haloperidol is one of the most common things that's used. Risperidone, olanzapine, quetiapine, all of these could be used. Remember that patients can have emotional and spiritual distress as well. So we want to provide them physical contact. We want to try and have a comforting mood as much as possible. We want to include them in that process of dying. And we want to be present with them, which is important. I mentioned terminal agitation, and the two most common things that are used are Haldol and phenobarbital. Sometimes there can actually be drips done to treat this. We don't know why terminal agitation occurs. Maybe it's because of some of the other medications. Maybe it's because we've removed some of their regular medications. Maybe there's an infectious process, or there's some ischemia occurring. Maybe they have renal failure, or maybe they've got an intracranial problem that's occurring. It could be because of urinary retention, or a urinary infection, or metastasis. Nausea and vomiting is another commonly seen symptom. 60% of the persons at end of life had nausea, and 30% had vomiting. So thinking about which medications could be used: ondansetron, promethazine, prochlorperazine, diphenhydramine, dexamethasone. Sometimes we use a combination of things. Terminal secretions, as I mentioned earlier, there's really no evidence-based studies that say any of these medications work to effectively treat terminal secretions. Some of them work for some persons, but not all treatments work for every person. So you may have to try, see if anything happens within 12 hours, and then change. But scopolamine patches, hyoscyamine, atropine drops, glycopyrrolate sub-Q or IV, if they do have IV access still. So a few options there. We talked about suffering, and refractory suffering is also sometimes a part of end-of-life care. And we have a protocol now where that sedation can be done for refractory suffering, where that really, it's keeping them not really aware of all the things that are happening around them, and giving them that opportunity to not suffer and to die in peace. I mentioned earlier orders adjustments. So, at the point that a person is put on comfort care or on hospice, we discontinue everything that's not for comfort. Vital signs are taken maybe once every 24 hours, but keeping them comfortable. If they, for example, have had a hip fracture, ensuring they've got a Foley or a Pure Wick to try and decrease that discomfort with turning. Using oxygen not to get their saturations up, but oxygen just to where they feel better. It's just for comfort. Having suction available, again, for comfort, and giving them a diet that they can tolerate. We want to discontinue any therapies that are not for comfort. So someone who's on hospice who is early in their time period there, then maybe they still get their thyroid medications. But we're going to discontinue those when we truly are at end of life. Chemotherapeutic agents, blood transfusions, antibiotics, IV, any fluids, PT, OT, speech therapy, those are going to get discontinued. Realizing that we're not going to always withhold all antibiotics, but let's say someone has a urinary tract infection, then yes, we might treat them with antibiotics to give them more comfort. We're not treating to cure everything, but more for comfort. In the palliative referral process, it's important to consider having a list of triggers. And it might be that in your electronic health record, it automatically can trigger this to ask the physician to write an order for a palliative care referral. It is important that if something's triggered, a decision is made to make a referral to palliative care, that if it's emergent, that it's documented as emergent in the request. I go to the emergency department. My colleagues go to the emergency department, to the point that on a daily basis, one of us is designated as the emergency department person for palliative care. So having a list of triggers that says patients should be referred to the palliative care team. If there's a lot of suffering, there's complex psychosocial issues, or a high probability of death, someone who's over the age of 65 and or has a chronic life-limiting illness like metastatic cancer, end-stage CHF, end-stage COPD. Functional status, if they're bedbound, if there's low caregiver or social support, if they've been in the emergency department fairly frequently and set a time frame. Is it 3 visits in 3 months? That's what some electronic health records use. Think about, would you be surprised if they lived for another 12 months? Because that's a good indication that they are entering that period of being near end of life. A referral can be made by a PCP, by a hospitalist, or a specialist, but someone has to certify that a patient is the anticipated life expectancy for them is less than 6 months for a hospice referral. Palliative does not require that. Both of these services give an extra layer of support for the patient and their family, for them to be able to manage symptoms or improve their quality of life. It can reduce hospitalizations and future unnecessary ED visits while keeping the patient comfortable at home. And it can assist the patient in developing their advanced directives that coincide with what their goals of care are. We want to also try and identify those psychosocial needs. Everyone is different. Every family is different. So we do want to treat these patients and their families with dignity and respect. And some of the patients that I've seen that's had the biggest challenge are patients that maybe have a history of substance use in their past, and now they really do need the use of substances to help them with current condition and current symptoms. Sometimes you meet patients that really fear the dying process, or maybe there's some unresolved family concerns that haven't been worked out yet, or there's financial concerns because the spouse that's going to be left, everything is in the spouse's name that's dying, and they're really worried about not having a place to live or not having the ability to afford food. Guilt is many times rolled up into that. Maybe it's guilt that the daughter or the son is younger and they haven't seen their parent in the last year because they moved across country and they're now living in Oregon. There's a great YouTube on what really matters at end of life, and I suggest that you Google and look for it and look at it, because that really does give some perspective. Some things that as healthcare providers that we can do if we're in an inpatient setting, or even if we're in a setting, say in long-term care, where that psychosocial needs are needing to be met, realize that maybe we need to relax visiting hours. Maybe we need to allow children in that are younger than what the policy says. We do want to reinforce whatever the patient's wishes are and think about those bereavement needs. We have to encourage caregivers to take care of themselves. And many times they want to just stay at the hospital or stay in the long-term care facility with them at their side because they fear the family member dying alone. And I just want to remind you that not all patients want someone with them when they die. Some things that can be done with the nursing staff and chaplaincy to try and ensure that there's some little mementos or some ways to kind of remember this process and things with the patient is maybe a lock of hair that's saved. Maybe there's a hand or a footprint created. And in the ER, when I had children that actually died with us, I would always get the footprint pad, the ink pad from the nursery, and use that to make hand or feet prints, regardless of the age of the patient. Our chaplain used to do sometimes blessings, other times baptismal, but would always use a seashell they had picked up at the beach to put the holy water in. And then afterwards, that seashell was given to the family kind of as a remembrance memento from that. Something else that I did in hospice is that our art therapy program would create hand molds with the patient. And maybe that's just of the patient's hand, or maybe that's of the patient holding their spouse's hand, or of a father and daughter, etc. Recordings. And in today's world, with cell phones that actually have the ability to record on them, sometimes it's just a matter of reminding people that that's something that can be done and shared, where that there's, a recording where that their grandchild could hear their voice when they get older. Having cards. I had one woman who had metastatic breast cancer, and she was really worried about her two children, especially her daughter, and not being able to be there when they graduated from high school or when her daughter got married. And so she wanted to be able to write some special cards. The problem was she couldn't write at that point. And so we talked with her. We found out more about what she would like those cards to look like. And we went shopping and we brought her back cards so she could choose what she wanted. And then we sat and we wrote her words for her so that she would be able to leave those with the family to be able to give to her daughter on those very special occasions with them. So as a nurse, many times we're really blessed by the work that we do with these patients. Remember that the whole goal of hospice is to treat patients and their family with dignity and respect, to care for them, respect their wishes, allow them dignity, let them have personal fulfillment. Hospice doesn't hasten or postpone death. It just affirms the life that's present currently. And being able to support that emotional, social, and spiritual needs. When I was in Colorado, one of the things that I loved is one of our social workers was actually a veteran. And we ask every patient about their veteran status. And we actually would do a recognition ceremony for that veteran and give them a certificate, give them a flag pin that they could wear. And that was just so moving to be a part of many of those ceremonies with the patient and the family. Realize that the average time on hospice is only 70 days, so just over 2 months. Now, I have to tell you that about 15 years ago, that number was 2 days for average time on hospice because referrals were just not being made. And now referrals are being made and people are getting the care that they need. And I think that when patients get plugged into palliative care, where that the patient can be watched and monitored and their wishes known, and then when it comes the time that they're meeting that criteria for hospice, they're then referred for hospice is helpful. Many outpatient hospice programs now also have palliative care as a part of their program. So planning for end-of-life care, just realize that many people fear that dying process, and something that we as nurses can do is help guide them in that process. Ensuring that they get spiritual and emotional care. Some of the biggest joys have been being able to watch reunions between family that have been estranged for a really long time and letting them to be able to make peace with each other. Oftentimes people need help at home. They just are not able to do all the things that they could do before because they don't have the energy and the effort. And I'm going to apologize, but we're having a major storm where I'm at now. So if you hear noise sounding like thunder or rain, it's thundering, raining, and it's coming down pretty hard right now. But hospice many times has volunteers who will do simple things like keep someone's little garden bed up so that they can see their flowers. Inpatient care sometimes is done as respite. Inpatient care is sometimes where people need to be. And if they meet the criteria for hospice inpatient care, when they're inpatient, we can move them to an inpatient hospice unit. Sometimes they stay very full. And so lots of times we'll provide hospice care within the hospital setting while we're waiting. Bereavement support is offered through insurance for all families. And that's something that I see many times families don't take advantage of, but we need to ensure that they're aware of that. The criteria for a person to be what we call GIP or general inpatient hospice is they have to have a qualifying symptom and there has to be symptom management. So this is a pretty good list. If they've got uncontrolled pain or seizures or complex wound care that they couldn't be managed in another way, symptom management, complicated medication delivery, if they suddenly deteriorate requiring more intensive nursing interventions, all of these could be reasons for general inpatient. Many hospice programs at the very end of life will have nurse care in the home 24 hours a day if that's what's needed for a couple of days. I mentioned earlier, unresolved family concerns. Sometimes there's that conflict about the medical decision. The patient always has first choice, first ability to say what their concerns are. They have to have that autonomy without any external control or influence. There's also sometimes difficult relationships, but that ability for forgiveness and gratitude and love and the ability to say goodbye. And sometimes we have to do that via phone or FaceTime or WhatsApp or some other technology, and encouraging patients to be able to do that with their families. Just realizing that terminal illness sometimes can be a gift to be able to wrap up some of those things in life that have just kind of been hanging out there and to make it better. Realize that during the dying process, sometimes bereaved family members are really distressed and maybe thinking they're not getting what they need, but it's important to listen. They might be concerned about emotional needs of themselves or the family. And bereavement really is a necessary part of the follow-up. One interesting thing I found was this one study that showed that family members were frustrated if they didn't get a follow-up phone call from the primary care physician if their loved one passed away. They said that they'd get a call if there was an unresolved medical question, but otherwise they weren't getting phone calls. So I know one of the things with our palliative care program that we do is we do send cards. Previously in hospice, we would send a sympathy card, but we would also send support cards at 3 and 6 months. And then at a year, kind of a thinking of you because it's been a year since the person died. And those can be very moving and helpful for patients. Oftentimes there can be unresolved financial concerns for a patient. Hospice covers their visits and the services of the care team. They only cover medications for symptoms related to their hospice diagnosis. It does cover durable medical equipment. So someone on hospice, the team can put a hospital bed in the home. They can put a bedside commode. They can do a shower chair. They can help with walkers, all of those things. They also will cover short-term inpatient care and short-term respite care, frequently up to 5 days, so that family can get a break. And then that grief and loss bereavement counseling as well. That Medicare hospice benefit doesn't cover treatment to cure terminal illness, medications to cure illness, room and board in a nursing home or hospice residential facility. So family would need to pay for that, or another insurance would need to pay for that. And then it doesn't cover care in an ER or ambulance transport like the patient scenario we talked about earlier, unless they've arranged it. Usually most insurance companies follow the CMS guidelines, but there may be that inpatient day limit. When we think about where people actually die, the majority of people die at home, either in their private residence or if the nursing home is their home or a residential facility. Almost a third die in a hospice inpatient facility, and only 7% actually die in the hospital. That home hospice, as I mentioned, could be in someone's home, it could be an independent living, it could be an assisted living, or a skilled nursing facility. When we talk about inpatient hospice, there could be a freestanding hospice home. One of the most beautiful ones that I've seen and worked in was actually in Cheyenne, Wyoming. They had a beautiful hospice home there that was freestanding facility. And otherwise, it might be a floor or a unit or designated beds in a hospital. Anytime a patient moves between areas, there's the risk of there being environmental challenges for them. So loneliness if they're in a room by themselves, although other people may prefer to be in a room by themselves. So it's important to ask. For elderly people at the end of life, being able to get time outdoors is really important for them. I loved working in one inpatient hospice unit that was a part of a hospital where the hospital was square and built around a courtyard, and there were trees and birds in the courtyard. And as a nurse practitioner, I got to write orders that the nurses and the aides could take the patient outside on a stretcher or in a wheelchair to be able to be out of doors. Not having privacy is another aspect of stress for patients that are in the hospital. So again, that's important to consider whether they would prefer to have someone in the room with them or not. There's a lot of support services available for most programs. So the case managers, social workers, chaplain, the nurses and the aides, music and art therapy, massage therapist, therapy dogs, and volunteers. And sometimes art therapy, massage therapy, and therapy dogs are all volunteers. But learning what the resources are in your area. You know, palliative care is really a support service. And from an inpatient perspective, there's one study that shows that if a palliative care consult is done and we truly understand patient wishes, that we can actually reduce the hospital cost for the hospital. And 90% of hospitals that are larger than 300 beds have a palliative care program. And about 67% of those with 50 beds have a palliative care program. But what that means is that in many rural community hospitals, they don't. We have, the program I have has 4 hospitals, and we have 2 that are in rural environments that we provide the palliative care in. But knowing what's available where you are. You also have to spend some time thinking about your personal view, because in general, our society denies the reality of death. And maybe that's because of previous experience. Maybe it's because of the circumstances surrounding death. And many times medical professionals view death as a failure. And I have to bring up the concept of futility, because the care we provide is never futile, but medical interventions sometimes are. And I think that care is considered futile if it's not consistent with what the patient's goals or medical practice standards of care are. And medical professionals might perceive this intervention or care as futile, but the family or the patient might say, well, this is really valuable. And sometimes that creates a conflict about doing the right things. And I've had physicians in the past say, you know that if we have to code them one more time, they're dead. Can you please get the family to a DNR, do not resuscitate status? And I had to say, we present the options, we give the information, but it's really up to the patient and the family to make those decisions. So we do want to educate. That's a big part of what we do. Assess at every time we as a nurse interact with a patient about their advanced directives, and offer support with every visit that we see them. There is a great My Directives app that you can use to put your wishes and to share that with other people as well. And I want to just, thank you for taking the opportunity for being here and learning a little bit more about palliative care and the differences between palliative and hospice. We are challenged many times because a patient's family may wish for everything to be done. And after several conversations, that tone may change. You do have to think about how you care for yourself. And I want to mention and ask you all to look up the pause. Just Google the pause. This was created by one of my colleagues, Jonathan Bartels, when we worked together in emergency medicine, and he's now a palliative care practitioner as well. But the pause was created as a way that when people die, for us to honor them and the work that we've done with them, and to take a moment to have a deep breath. And this is sometimes done with the family present as well, but it also gives us an opportunity to reset before we go back and take care of the next patient that's waiting for us as a provider. There's a long list of resources. As I've said, you're welcome to my slides. I'm going to check the chat box now just to see what questions that we might have. And if you have questions, you're welcome to speak up, raise your hand. We can get your mic unmuted so that you can ask those, or you can ask questions, excuse me, in the chat box. This is being recorded and it's going to be available on the webpage. And I am happy to share my slides with you as well. And I will put my email address in the chat box.
And everyone is always welcome to reach out to GRNEN to, if for whatever reason you have a question later or you're having trouble getting the video, we should have the recording on our website by tomorrow, for future viewing or to share with your colleagues. But you can reach out to us and we can help filter you through to the right channels if necessary. Is there any questions? Okay. Well, in conclusion, I just again want to thank everyone for taking time out of their day to join us. And most especially, thank you, Audrey, for always being so willing to provide this information to our community and to guide us with these really important and informative conversations. So thank you for being here. I hope that your storm passes quickly. And I hope everyone has a wonderful rest of their day. Take care now.